Good morning, everyone. Welcome to the Health Services Research Grand Rounds. Today is the opening session of the 2025-26 series. And we have a very exciting speaker that I will introduce shortly. Before we start, just a few housekeeping notes. This meeting is recorded. It will be available for public viewing and will be posted on our website. If you have any questions, you can post it on the chat window, the Q&A window. It can be seen by everyone. If you'd like to post your question anonymously, you can do that so too. For any technical assistance, please reach out to Abigail Zona or Nicole Bollinger, who are on the line. And with this, I'd like to introduce our first speaker for the 2025-26 Health Services Research Grand Rounds, Dr. Varun Sundaram. My colleague, Dr. Varun Sundaram, is a heart failure cardiologist at University Hospital's Cleveland Medical Center and the section chief of advanced heart failure at the Cleveland Veteran Affairs Medical Center. He's an associate professor of medicine at the Case Western Reserve University School of Medicine and also serves as the deputy director of the Health Services Research Center at University Hospitals. He completed his clinical training in internal medicine and cardiology in Cleveland before pursuing advanced clinical and research training in advanced heart failure in London. In 2020, he earned a PhD from the National Heart and Lung Institute at Imperial College London, followed by an MSc in clinical trials from the University of Oxford in 2023. Varun is an NIH-funded investigator, leads a team of postdoctoral scholars and research fellows with a focus on heart failure epidemiology, leveraging electronic health records and clinical trials. He's a fellow of the Royal College of Physicians, Glasgow, and has received multiple accolades, including the Early Career Research Award from the American Heart Rhythm Society in 2026. With this, I welcome you, Varun, to our grand rounds. Thank you.
Thanks, Dr. Bora, for the nice introduction. So I'll share my slides. So can you see the slides?
Yes, we can.
Yeah, okay. So thank you for the opportunity. So today I'll talk about how global epidemiology of heart failure has to be used in the context of trial interpretation and informing trial designs, and how we cannot get away without that. So this is going to be the outline for today's talk, where I'll start with the existing data sources of epidemiological research, the global practice patterns in heart failure epidemiology, and its implication for clinical trials and heart failure, and how we might have to rethink trial design and interpretation of trials more so, and conclusion. So the data sources for epidemiological research can be broadly categorized into three resources. One is data from clinical trials, which could be used for epidemiological research. Second is registries and large community cohorts, such as Framingham cohort is one example which many people are aware of. And then comes the administrative claims databases or electronic health records. Most of the data sources could be categorized into one of these three. So let's start with clinical trials data. So we all know that randomized clinical trials are the most effective way, or the only way of answering questions related to estimating treatment effects. That is the gold standard study design as of now. And the primary analysis, as most of you know, is pre-specified before anyone has even seen the data. And at times, you even have pre-specified secondary analysis. But mostly secondary analysis and post-hoc analysis could be done after the trial is completed and published, where you have a rich data source of, let's say, for example, in heart failure, the most recent phase 3 trials have around close to 5,000 patients. So you have 5,000 patients with heart failure with an average follow-up of around 2 to 3 years, a very rich data source which you could use to answer questions related to heart failure epidemiology. So this is data from clinical trials, which you're using for other reasons, that is to answer important epidemiological questions. One such example right now is this study published in New England Journal of Medicine. So where there are two modes of death in patients with heart failure. One is sudden cardiac death from arrhythmias. You have life-threatening arrhythmias, which can cause sudden cardiac death. Patients just die right away. Or second is progressive pump failure, that the heart as a pump fails over time. These are the two modes of death. So there has been increasing evidence to suggest that with newer medications, a sudden cardiac death reduction is more profound than the pump failure. And why is this important? It's because one treatment called implantable cardioverter defibrillators, which we use, just mitigates one aspect of it, that is the sudden cardiac death. It does not do anything for the pump failure mode of death. So the investigators compiled trials from all heart failure trials data, compiled evidence from all heart failure trials data over 2 decades, and looked at the rate of sudden cardiac death. And as you could see in modern medical therapy, background medical therapy, the rates of sudden cardiac death have declined significantly. And this has implications now because we start to question the role or the risk-benefit ratio of implantable cardioverter defibrillators in modern-day practice at the background medical therapy now. So because a sudden cardiac death is on the decline. So this is one way where a rich data source from trials could be used to answer epidemiological questions related to the disease per se. However, our trial data, as most of you know, comes with important limitations as it has strict inclusion and exclusion criteria. On an average, less than 30%, 30 to 40% of patients who are screened are randomized. So, and this is done for the right reasons because you don't want to include patients who are non-compliant. You want to have a more homogeneous patient population to maintain internal validity. But then this comes at a cost. At the cost of maintaining internal validity and using a strict inclusion and exclusion criteria, it's a trade-off. You're going to have decreased external validity or generalizability. For example, so if you had started with screening, let's say 10,000 heart failure patients, you would end up in 3,000 patients. And you've lost almost 7,000 patients seen in clinical practice. And you're answering epidemiological questions from these 3,000 patients, which may not reflect the entire spectrum of patients who you see in real world. So real world is a term which I use very cautiously because it does not mean that patients in trials are from a different space, but it's just used for to say. So there is the generalizability is decreased when it comes to answering, especially epidemiological questions using trials data. That's something to be aware of. So what is more generalizable is registries and community-based cohorts. So registries are defined as systematic collection of defined events or product exposures in a defined patient population for a defined period of time. This is just a classical academic definition, which you don't even have to worry. But as you all know what registries are, some of the examples are drug or device registries, where you have the ICD registry for heart failure patients, the Medicare registry, the disease registry, the cancer registry, SEER registry, which is being used, and large community cohorts such as Framingham cohort and atherosclerosis. What it does is it's designed for a purpose where you collect patients prospectively over time. Okay. And one example of registries which we use is the National ICD registry, which we use to answer a question related to cardiac resynchronization therapy. So what is cardiac resynchronization therapy? Is a mode of pacing, a pacemaker in heart failure. A significant part of patients with heart failure have conduction disease, electrical conduction disease. And when you have electrical conduction disease, which we otherwise call as bundle branch block, the QRS duration in the ECG is wide. So this heart failure patients with very wide QRS duration tend to benefit from the sophisticated pacemaker called cardiac resynchronization therapy. It's just a mode of pacemaker. So earlier trials had compared patients with QRS duration of greater than 150 milliseconds and showed that cardiac resynchronization therapy works in this group of patients. But those with very wide QRS duration, those with greater than 180 milliseconds, were not studied in the trials. But in clinical practice, 25% of patients have a QRS duration of greater than 180 milliseconds, but this was underrepresented in the trials. This is so when you see a bundle branch block morphology, there is a wide QRS duration, a wide QRS in ECG. If it is less than 130 milliseconds, it can be related to something different than conduction disease. But when it is around 140 plus or minus 16 milliseconds, you know it's from true electrical conduction disease or bundle branch block, where And when it is greater than 180 milliseconds, it could be a combination of these two. In the first group, we know that putting in the CRT can harm. Patients died. Clinical trials have shown that patients died. The number needed to harm was much higher when there was a 20% relative increase in death when you put a pacemaker in this group. And in this group, there's a 10% absolute risk reduction, number needed to treat of 10, very striking with pacemaker. But we don't know what is it when it's a combination of these two. And that's what we studied. And contrary to our hypothesis, which we thought which would be neutral outcomes, it showed that those with very wide QRS duration, and here these are the two groups where you see much lower hazard ratio, and showing that so wider the QRS duration, greater is the benefit with CRT, and there is no clear upper limit which we could use to not give this pacemaker for patients with heart failure, because wider, they benefited more. That's what we concluded with the study using the registry of ICD registry, and a question which was not answered in clinical trials. So now, are registries gold standard for real world evidence? Certainly not. So because patients enrolled in registries are also prospectively recruited, right? So they are often recruited from tertiary medical centers. They're non-consecutively enrolled. And that means there's a selective enrollment. Some patients would not be enrolled. And we know from evidence that patients who are enrolled in registries are more closely followed compared to those who are not. So that means they are likely to be treated differently because they have access to coordinators, to call, and all of this. So they are likely to be treated differently. So this systematic error, owing to selection bias in patient registries, does make them susceptible to generalizable issues. So hence, making the registries may not necessarily be gold standard for real-world evidence. So what is a gold standard is nationally representative electronic health records. Not all electronic health records. There are electronic health records which are nationally representative on administrative claims. Some of the nationwide electronic health records are Medicare, so which includes only patients above the age of 65. So it represents those above the age of 65, generalizable. Veteran Affairs includes all veterans, so it's only generalizable to veterans, but includes all veterans. And certain health insurance database. Hospital base includes Kaiser. The advantage of this is all patient clinical encounters are captured, and you're not recruiting patients. So there's no selection bias. Patients are not selected, and all clinical encounters are captured in a well-done electronic, maintained electronic health records. So if you want to truly test the burden of disease in a population or true epidemiological studies, this is where you have the patient population which are unselected, consecutively enrolled with no selection bias, and a well-maintained, a well-structured electronic health records, which are nationally representative sample, would truly be the gold standard for epidemiological studies. So those are the three large categories. And so of epidemiological, for answering epidemiological questions. Let's look at global practice patterns in heart failure epidemiology. So the existing guidelines, both from various societies, do not account for variations in heart failure management in different countries. And the existing knowledge on transnational differences in heart failure population practice pattern and outcomes are limited to those from clinical trial databases and registries, which I just mentioned the issues with limitations. It's hard to say that this will truly reflect the epidemiological differences, studies using clinical trial databases and registries. Let's start with one of the geographic variation study in heart failure using clinical trials database. This is from a trial called Paradigm Heart Failure Trial published in 2015, where the investigators looked at patients recruited from different continents. As you can see, patients in Asia Pacific region were much younger and had a much lower body mass index and had much lower prevalence of certain comorbidities, including atrial fibrillation and diabetes. But the issue here could be is that the patients who are enrolled could be much younger and having much lower comorbidities. And it is possible that it is not that there's underlying differences, but there could be just underlying differences in enrollment as opposed to underlying true epidemiological differences. So The same group of investigators went ahead and built a prospective registry in Asia, because the Asian population was found quite different, and looked at this in a prospective heart failure registry across Asia. And these are the patients who were included in this prospective registry. And what they observed was in this Asian registry, Malays, that is people from Malaysia, heart failure patients were the youngest ethnic group, and there's significant heterogeneity across Asian nations. China had the lowest rate of optimal medical therapy for heart failure, while Indonesia had the highest. But what is striking here is, while this is more generalizable than clinical trials, look at the sample size. In a population of 1.5 billion, you have 477 patients from China who have been recruited in heart failure. So me coming from India, I can tell you 1,500 patients is definitely not a representation of the overall heart failure patient population. While it does add significant value, I applaud the investigators for going through the pain of actually building the registry and following up. It really adds value, but it does not. It's hard to say whether this truly reflects the fundamental underlying epidemiological differences in heart failure. So what would be an ideal resource for comparative epidemiological research? You should have nationally representative data of electronic health records, and should capture routine clinical encounters, negating selection bias. Should have diverse health systems, and the quality of electronic health records has to be good, because that's a very key issue. And it has to have individual patient level data and not patient aggregate data. So many electronic health records have patient aggregate data, and it's very hard to make firm conclusions, though it might give very good graphs and very good results, but it means nothing. So that has to be very limited use. So these are the things which would qualify for doing a true study underlying the epidemiological differences. So what we did was we built the data science infrastructure across developed countries across 3 different continents. So the easiest here was to actually get was the US datasets, which is almost open source. Anyone can go and access it. It's not, but the difficulty was getting all the other 3 to go through the data privacy regulations, which was from United Kingdom, Taiwan, and Japan, which had high quality electronic health records apart from Scandinavian countries. So the United Kingdom has an electronic health records which has 10% of the population randomly sampled with follow-up of up to 20 years. And Taiwan has the best electronic health records, which is 99% of the entire population. And Japan has something which has 600 health systems which have enrolled called JERO DPC. So first, as the step, we went through data privacy regulations, took years to get access, and we harmonized data. And we built common codes for diagnosis and for all comorbidities, because how diabetes is defined in Japan could be very different than how it is defined using ICD codes in US. So we built common codes, so for common extraction platforms for both diagnosis and procedures. And after building this data infrastructure, we answered the questions related to the fundamental differences in epidemiology in heart failure. So what we did was we identified close to 1 million patients across all these, as mentioned, 4 countries, developed countries across 3 different continents with very good electronic health records infrastructure. Use same inclusion and exclusion criteria, and arrived at the final cohort of heart failure hospitalizations, individual patients with heart failure hospitalizations, and try to understand the differences. What we observed was quite striking. So this is just looking at the differences in age. As you could see, compared to the US, that is both the US and Western Europe, that is UK, there's significantly higher proportion of elderly heart failure patients being hospitalized in Japan and Taiwan. So almost 70% of the heart failure hospitalizations in Japan was for those above the age of 85 years. Very striking. So just to show how different the patients are across when we try to get a nationally representative sample, which was not the case in the earlier 2 studies when they compared it with clinical trials and registries. And this is so, and moving further, trying to understand how different the patients were, you could see the highest prevalence of coronary artery disease was in Taiwan, followed by United States, and the least was in Japan. And There are much higher diabetics in the United States, and the least was in Taiwan, and the highest in Taiwan. So least was in Japan and highest in Taiwan. And the obesity rates, as expected, were much higher in the West compared to the Asian countries. And this goes with the prior hypothesis. As you could see here, Taiwan has the highest prevalence of diabetes, but the obesity rates are less than 1%. This tells us about the non-obese diabetic phenotype in Asians, who are more the lean diabetics compared to the obese diabetics in West. Just confirms the hypothesis. And significant differences in discharge within 24 hours of admission among patients hospitalized for heart failure across the 4 countries. And this just tells us the threshold for hospitalization and discharge may also be different across the countries. And this is persisted despite adjustment. And when we looked at procedural utilization, I was under the opinion that we were doing way more number of tests in US, but I was wrong when I actually looked at the end of the study. You could see almost the procedural utilization was way higher in Taiwan and Japan, especially in Japan. Almost 20% of patients who are hospitalized got coronary angiograms. Like right heart catheterizations were threefold higher in Japan compared to what it was in the United States. And coronary revascularization, as I mentioned earlier, Japan had the least rates. The prevalence of coronary artery disease was lowest in Japan, but the PCI, the revascularization rates were highest in Japan. So just tells you how high the procedural utilization is across across the 4 countries. How different the demographics is, how different the comorbidities, and how different the procedural utilization. And this was reflected in the median length of hospital stay. The median length of hospital stay was much higher in Japan, close to 17 days, the lowest in the United States, 4 days, and the age standardized hospitalized mortality, in-hospital mortality was lowest in the United States and much higher in other countries. But the readmission rates were on the higher side in US. This shows the fundamental differences in the true epidemiological differences in heart failure patients when we try to use a nationally representative sample. And this has much more implications than just the study, and I'll explain why. So this study identified patients with heart failure. But the issue with electronic health records, nationally representative electronic health records, is to phenotype heart failure into the 2 groups. There are 2 groups of heart failure. One is called heart failure with reduced ejection fraction. Another one is preserved ejection fraction. Roughly half of the patients, the split is just half and half, roughly. So, and that's from the data from the Western world. So what we did was, what can we do to identify the different phenotypes of heart failure, because the treatment management varies based on the different phenotypes in electronic health records. That was so we did a prospective survey, randomly sampled patients from the United Kingdom using a nationally representative sample. And since surveys sampled the patients with heart failure and sent surveys to the physicians, and then got information and compared and built algorithms for identification of individual heart failure phenotypes. This is a prospective survey. And what we identified was certain algorithms for identifying patients with independent heart failure phenotypes, because we don't have the individual echo data in nationally representative electronic health records. So we had to build surrogates to identify the individual heart failure phenotypes. And then subsequently, we actually had another scoring system, which was published in Nature Medicine, which we validated in 7 countries, Belgium, Japan, Australia, Denmark, and another 4 institutions in US for identifying individual heart failure phenotypes within electronic health records. So now trying to compile the 3 data resources for epidemiology. The generalizability, this is moving from clinical trials database to registries to claims. The generalizability increases as you move from clinical trials to electronic health records for the reasons which I mentioned, because there's no selection bias. The data from clinical trials, however, is quite rich. For a small number of patients, you have more richer data and more reliable data than what you have in claims and electronic health records. And the power for subgroup analysis increases as you move from clinical trials to claims and electronic health records. But the issue with the electronic health records is it's quite difficult and expensive to get the good nationally representative electronic health records. And the data management is quite complicated because it requires extensive data cleaning. And in my experience, there are 1,000 reasons why it could go wrong. And if you get the data cleaning wrong, the whole study is wrong. What you analyze from it is wrong. So it's very time consuming, extremely time consuming, expensive, but it gives you the answer for the respective questions in epidemiology. So what are the implications of these findings for clinical trials in heart failure? This is in terms of interpretation and in terms of consumption of evidence. So this is going back to our results of our study, showing the differences in threshold for heart failure hospitalization. That's the first, significantly differed across countries. So with US having the least threshold for heart failure hospitalization and Taiwan having the highest threshold. And the length of hospital stay is quite different. And as I mentioned, the healthcare resource utilization is quite different. And that was reflected in because more healthcare resource utilization, more length of hospital stay could be reflected in the in-hospital mortality along with the severity of heart failure. And even while adjusting for baseline severity of heart failure, we found differences in the rates of admissions, readmissions, or rehospitalizations. And why is this very important to understand that even despite adjustment, the thresholds for admission, for heart failure hospitalization and discharge, and healthcare resource utilization, length of hospital stay are different despite adjusting? Is because these are the endpoints which are studied in clinical trials. So most of the clinical trials in heart failure use time to heart failure hospitalization as an endpoint. Some use even length of hospital stay, phase 2 studies, and rehospitalization is another endpoint. So while we would like to believe that all outcomes, what we want in a trial is the outcomes only reflect the differences in treatment between the treated and untreated group. And we don't want it to reflect the differences between the two patient groups, which is what randomization takes care. So when you when you interpret results of clinical trials, often it's only due to the differences or lack of difference, what you think is only related to biology or treatment, differences in biology or treatment effects. But often it can also be related to some issues with trial population or trial conduct. So we assume that it's only from treatment, but at times it may not be the case, or often sometimes we've been seeing it increasingly, that's not the case. So it's very important to tease out which one, and especially understanding the epidemiology in the disease context, to go and look which actually influences the results, and how do you inform trial conduct in the future based on the epidemiological differences. So some of this trial context could be, the practice patterns and cultural differences, which I will come to in a bit. So in heart failure with preserved ejection fraction, until recently, we had no drug. This is roughly 3 million patients in the United States had the specific phenotype of heart failure called heart failure with preserved ejection fraction. There was no drug for this group, whereas in HFrEF, that is reduced ejection fraction, we had lots of drugs. So this was the first, one of the major trials which we're really hoping for to have a positive outcome in a disease where there's no treatment available. So this is testing spironolactone in patients with heart failure with preserved ejection fraction. Spironolactone is used in resistant hypertension and kidney disease to an extent, and spironolactone is a mineralocorticoreceptor antagonist. So what this trial showed was the trial results close to more than 4,000, 5,000 patients with heart failure with preserved ejection fraction randomized to spironolactone and no spironolactone. The primary outcome, the results were largely neutral, which is quite disappointing for us. But there's something which we actually learned from this trial, which is one of the landmark trials in cardiology, is the investigators did subgroup analysis. As you all know, subgroups are just hypothesis generating. It's not hypothesis testing. We have to always take it with a pinch of salt. Because this is a global trial from multiple countries. They actually did a regional analysis, just taking patients from Russia and Georgia and comparing those who were enrolled in America. What you're seeing is the difference in treatment effect between the placebo and treatment among those who are enrolled in the United States compared to those who are enrolled in Russia and Georgia. But what is even more important is it does not probably reflect treatment heterogeneity. I think it's hard to say, oh, the drug works in those in the United States compared to those in Georgia for one reason. I would urge you to look at just the event rates in Russia and Georgia. Just the event rates, even in the placebo group, are very, very low. So compared to the event rates in the placebo group, the placebo is one thing. The placebo, the event rates are almost 2.5 or 3 times higher in the control group in the patients enrolled in the United States compared to those in Georgia. This raised the question, what is the pattern or phenotype of heart failure patients who were enrolled in Russia and Georgia? So the trial had 2 inclusion strata. One is you had to either have recent heart failure hospitalization, or second, have elevated natriuretic peptides. It's a biomarker for heart failure, which we use. So when you look at it closely, what you observe is a significant part of patients in Russia and Georgia came through the first strata, that is recent heart failure hospitalization, and only 11% of patients came with a more objective evidence of natriuretic peptides. Elevated natriuretic peptides for heart failure is more objective than what heart failure hospitalization is subjective, left to the investigator's discretion to enroll. So, and having so, if you've had previous heart failure hospitalization, you're likely to have more heart failure hospitalizations later in the future. That goes against these patients in Russia and Georgia had more prior heart failure hospitalizations, but didn't have much heart failure hospitalizations later, raising the question whether they truly had heart failure, or is it just a different variation of heart failure which we're not used to. So here is a thing where it tells us the trial conduct or the trial population could have been the reason why we noticed we had a neutral effect as opposed to the treatment not working or the treatment effects. Something which we missed, a very costly, expensive mistake. As you all know, trials are very, very expensive. So I see one of my colleagues from Scotland who's logged in from the trials unit. He told me that the last trial, which was done from their group, costed $400-500 million, which I'm going to show now. So that's industry-based trial. So it is. So you have. So the answer is not that the drug did not work. We don't know the answer. It could also be related to differences in trial conduct or epidemiological differences in patient population. So the guidelines had recommended this as class 2A. So it didn't, it still indicated, but as class 2A level of evidence. And so now you had another drug, these called under the same class, mineralocorticoid receptor antagonist, but it's non-steroidal compared to the steroidal. Spironolactone is steroidal, this is non-steroidal antagonist from Bayer called Findrenone, which is studied in patients with heart failure with preserved ejection fraction. What they observed was a reduction in the event rates. This is a different drug, but under the same class, a reduction in the event rates and a positive trial. So now, in this trial, we learned from the mistakes of TOPCAT. So they didn't have the strata of heart failure hospitalization, that everyone had to have elevated natriuretic peptides. So now you've had one trial with steroidal MRA, which is mineralocorticoid spironolactone showing neutral. Another one, it's a different drug, and one is generic. Another one is just being filed to FDA for approval for this. The drug has been approved for chronic kidney disease, but it's been filed to FDA for approval for heart failure with preserved ejection fraction. So the question comes, if you're looking at strict interpretation, and if I'm looking and I'm sitting in the guidelines committee of FDA, I have to say that Findrenone works, but there's no evidence to show that spironolactone works. So I cannot say that there is, when we say there is no evidence, it's a fancy term, but we have to be more clear whether there is evidence of absent effect or absence of evidence. That is, you do a trial and there is no effect, a well-done trial, or you're still unsure of the evidence. In spironolactone, what I would call is there is absence of evidence rather than evidence to show that there is neutral effect. But unfortunately, we'll have to approve. So the generic drug, which is $3 now, there is no evidence to show superiority or equivalence with Findrenone. And once it's generic, it's actually the appetite to do trials is also goes because So as I pointed out, while it could be the two drugs are different, one is better than other. That's what some investigators claim. But it could very well be that the differences observed were related to differences in trial conduct or trial population which are recruited, epidemiological differences. And or it could also be that, as I mentioned, differences in trial conduct, and this comes under the same class, and it could probably just be a class effect as opposed to two individual drug effects. These come under the same class. And there is an ongoing trial called Spirit HF trial, another one in US. But unfortunately, I just spoke to the investigators in Germany who are doing this. They said they had to close the trial prematurely due to difficulties with recruitment, because many investigators don't feel that there is a clinical equipoise to randomize patients because they are already on spironolactone. So it's very hard to do this trial anymore. So the question comes, it's an important question, because it's in a resource limited settings in major part of the world. So you're still saying that spironolactone, we are having absence of evidence, but it's still being interpreted as it does not work, which could be it's not working, but there's no clear evidence to show. And you're, as a policymaker, you're left with a drug which with no clear evidence, whereas a drug with evidence, as opposed to drug which works, as opposed to drug which does not work. That's how it's interpreted. So it's an understanding of the trial population and a trial conduct. I mean, it's something which you've learned from previous trials. All of us learned from this. It could make a huge difference in terms of economics, especially in a disease where there's not many treatment options. So when you go back and compare the trials, again, these two trials, the TopCat, spironolactone, and Findenol, when you look at the primary outcomes are subtly different between the two. They're not the same. And you see a neutral in one and positive in another. And but when you're looking at the time to first heart failure hospitalization, again, this is a secondary outcome, and it's hypothesis generating, not hypothesis testing. But look at the point estimate between the two. It's 0.83 and 0.82 when you compare the two. So I was just looking at it because it's very hard for me to say that there's no class effect. I know that there's a lot written about saying that these two drugs are different. Yes, they are different, but are they different enough to show that they are actually, these two are truly clinically different, to have clinically meaningful difference? And you see a much shorter confidence interval in Findenol and a much lower p-value. There is more confidence in the results, largely because of the event rates. You have almost 4 times the events in number of events in the fine arts trial compared to the spironolactone trial, because as I showed you, the Russia and Georgia population did not have enough heart failure hospitalizations. This large number of events is reflected in the narrow confidence interval and much lower p-value, but with similar point estimate. So my take on this is a class effect cannot be ruled out. There's no evidence to, so it is just absence of evidence with spironolactone. I don't think we have enough evidence to show that these two drugs are they are pharmacologically somewhat different, steroidal and non-steroidal. Whether that difference within the same class is enough to explain meaningful differences in clinical outcomes is a question which we don't know. And we'll never have a trial comparing these two because it would require tremendous large sample size because of the small difference. And who's going to do the trial? So no one would be interested to doing the trial. So again, this is to say how epidemiology and trial conducts, can inform trial conducts in the future. So recently, in the European Society of Heart Failure, there was this late breaker which was presented showing that from Findenol, comparing it with TopCat trial, showing that both these drugs can cause hyperkalemia, Findenol less so than spironolactone, that there were more premature discontinuations with spironolactone compared to Findenol. That means saying that Findenol is better tolerated compared to spironolactone. So while the efficacy could be the same, this drug is better tolerated compared to the other drug. But again, I noticed something which is very, when it's not published yet, but it's out in the news quite a bit. When I looked at it, the spironolactone data was analyzed only from TopCat America, not from the entire TopCat. The Findenol is a global trial, the fine arts, whereas TopCat America is only from America. It was not including the other population. And having practiced transatlantic, both in UK and in US and outside US, I can tell you, and it's likely, I cannot be certain, the discontinuation rates are likely to be different across countries because defensive medicine is much more here compared to other places. So when we see a rise in potassium, we are more likely to actually to stop the drug. So it is not a global trial comparing global trial. There is clear differences in the threshold of drug discontinuation when you're comparing only trial done in America compared to a global trial. So this may not just be enough evidence to show that the premature discontinuation, this is driven, could be, I can't say for sure, could be driven by differences in practice pattern as opposed to differences in how the drug per se is. So moving forward, how do we rethink trial design and interpretation more so using the epidemiological data? As I told you, how important trial population eligibility criteria and how we could use through epidemiological studies to identify the right trial population, especially when you're doing global clinical trials. And second is the event rates. As I showed you, the event rates are vastly differing across countries, and that's going to have implication in the sample size estimations. Of course, some trials are outcome based, that is, you wait for a certain number of outcomes to be accrued before stopping the trial as opposed to the number, and that it may not, but still, it's very important to be cognizant that the outcomes are quite different, and that was the case in TopCat too. And next comes randomization. So we all know randomization is a gold standard, and most drugs or devices, all what we do, just have moderate treatment effects. When Alexander Fleming came up with penicillin, that's the best example I could come with, to treat penicillin-susceptible bacteria, you didn't need a trial because the number needed to treat is 1. When you have large treatment effects, you don't need a trial to show. You just, an observation or observational study is enough. But most of what we do has just modest treatment effects, that is 10 to 30% relative terms. Then you could argue it's only small. Why do we even test a drug? But that's because when you have multiple drugs with moderate treatment, moderate relative risk reduction, it eventually accrues to a large treatment reduction. So for example, in heart failure, the annual mortality was 35 to 40% in 1990, and now it's 7%. A 33% absolute risk reduction, a number needed to treat a 3 for all the drugs put together for reducing mortality. That's how striking when you add all multiple drugs with moderate treatment effects. So, and the reason for moderate effect size is every drug just affects one pathway, but there are multiple pathways implicated in the disease and in the pathophysiologic progression. Often these moderate effects stands because it's just moderate treatment effects. It can be missed by systematic errors, the two groups being systematically different, which could be eliminated by randomization. And there could be some random error, but that could be quantified by p-value. But when it comes to randomization, we make sure that patients are randomized at baseline. That's something which we could check, and we do. But what we don't know is imbalances in the two groups post-randomization. Like how I pointed out that the differences in procedure utilization, how procedures are done, are quite different across countries. Post-randomization, most of these patients are going to be followed. You could argue that the patients between the two groups in each country are equally randomized between the two groups, but still it's not the same. So what happens, for example, is you could have imbalances post-randomization. And one example is, this is one of the trials of SGLT2 inhibitors, a diabetic drug in heart failure, and showed a reduction in heart failure hospitalization and mortality. But what I would like to point out is this trial was published in 2020, started around 2015. But when the trial started, a new drug called angiotensin receptor neprilysin inhibitor was approved just for heart failure. So at baseline, only 18 to 20% patients were on this drug, which is fine because the trial was. But during follow-up, the uptake of this drug is going to be differential in different countries based on the individual practice patterns, individual insurance approvals, individual country's policy of, like in UK, you have National Institute of Clinical Excellence approval, the drug is available. In US, you have independent insurance companies had to approve. And in Asia, some of these countries had patients who were paying from their pocket. So the uptake of this drug is going to be quite different. And this is a powerful drug. It can influence outcomes. So the imbalances in co-intervention post-randomization, there is differences in co-intervention post-randomization based on individual practice patterns can affect. And this is just for drug, but what about all the procedural differences or how it's done across it? they can actually possibly influence, not always, possibly influence, and it's very important because to be aware of. So, and finally, selection of outcomes. As I pointed out, I just showed, despite similar severity, the heart failure, the threshold for heart failure hospitalization, discharge, and readmissions are very different across countries, and the length of hospital stay and need for revascularization, which is one of the outcomes used in some interventional cardiology trials. That is strictly, to an extent, or largely uh, determined by individual practice patterns too across different countries. So truly epidemiological differences in how patients are managed across different countries. And treatment heterogeneity is last thing. So we know that beta blockers is one of the drugs used in heart failure. The dose tested was around 50 milligram, which reduced mortality by 35%. But not all patients outside US and Western Europe tolerate this dose. In Japan, they did this trial. So the maximal tolerated dose they could go up to was 10 milligram of carvedilol. That is almost 20% of the dose of what it is used here. So, but the effect size was quite similar. So the significant treatment heterogeneity across countries. So in conclusion, and with clinical trials becoming global, the last cardiology trial had recruited patients in heart failure from more than 70 countries. So increasing globalization of clinical trials means that understanding regional differences in heart failure epidemiology is absolutely essential for accurate interpretation and consumption of trial results. And these information from epidemiological information should be used to inform the design, eligibility criteria, endpoints, and operational conduct of future trials. Because misalignment between the trial design and epidemiological reality could be quite costly, especially with how trials are, and it can lead to missed signals in where the drug really works or non-generalizable findings. And epidemiological studies have to be routinely updated too, so with every decade, to really reflect what's happening around so that we could have a foundation for globally relevant and efficient trials. So thank you very much. And I'd like to thank all our funding bodies, NIH, AHA, VA, Merit, and for funding all our studies, and my team, research team, and my collaborators, international collaborators. Thank you very much for your attention.
Thank you, Varun, for a very comprehensive overview on a very important topic. And for the audience, please feel free to type your questions in the Q&A. As I mentioned earlier, you can type it there and everyone can see it. If you'd like to, if you'd prefer anonymous, then you can do that too as well. And Varun, there are also some questions in the chat.
Okay.
I see there are some questions there. But while others are typing their questions in the Q&A, I have a very, very, very basic question, and you have used this couple times about good electronic health record. So what really counts as good electronic health record data, or what would be the definition of a good electronic health record data? Is it, or what determines it? Is it generalizability, the richness, or as you say, power for subgroup analysis, or cost, or is a mix of both, or is it question specific?
Yeah, I think it's everything, but also I see the first question was asked, it does not capture everything. Yes, it does not capture everything in the sense it is very disease specific. So in fact, for example, in heart failure, for us, what was important was to capture mortality and heart failure hospitalization. So we had to do a validation study to see if the heart failure hospitalization was truly heart failure hospitalization before even embarking on the study. So where, for instance, I'll just give you an example where you have, this is just relation to the first question. So where you have admission diagnosis and discharge diagnosis, which is truly right. So we don't know, right? So at the time of admission, so what we had to do in UK was to actually have compared with coding patterns of if you have both admission and discharge is accurate, or if it's just either one is accurate, or if it's only discharge which is accurate. So we used both admission and discharge had to correlate to an extent. So it is while it has to be a representation of the population, where I mean capture routine encounters. What I mean is the major encounters. It may not pick all minor encounters, major encounters to an extent. For us in heart failure is heart failure hospitalization, mortality, and procedural utilization. At times, it depends. When you have out of state, when you're actually within one system and you go out of state, it's an issue. But some of the medical electronic health records, like Medicare, captures most of it because they have, and in other countries internationally, it captures all of it. So it depends on this question, and where even diagnosis, we had to validate heart failure diagnosis too and heart failure hospitalizations too, whether to see how accurate it is before embarking on the study. So good electronic health records, one, should be representative of the population. I mean, if you're going to do a true epidemiological study, population, randomly sampled, and then like how it is done in some countries, and in here it should include, for your disease, it should specific the important, it should capture the important encounters. Like you pointed out, insomnia is not captured. Yes, I think insomnia is not going to be captured right in this. So that is one. And then when you actually encounter large population, even small mistakes, you regress to the mean, because there's going to be some issues with billing and coding, right? So that's why when you have electronic health record study from just one health system, one small, very small health system, if a small, few mistakes, which will take you away from the mean, whereas you have millions of patients, even small errors, you're likely to regress to the mean. So that would, when you actually have large nationally representative electronic health records, where diagnosis and codes specific to your disease is validated, would be the right one, which I would use. And recent relative benefit of treatment as other therapies. For instance, there is some other.
So Varun,
I
for
think
questions in the chat, you may have to just repeat it because audience can see.
Yeah, so the chat question is, hospitalization varies based on the comfort of provider, and whereas death is a hard endpoint. Interesting point is the decrease in relative benefit of treatments as other therapies becomes available. For instance, beta blockers are amazing medications for heart failure, but given other drugs, now what would be the relative benefit of treatments? I think I would agree and disagree both on this. So one, what we have done even in beta blocker now is the relative risk reduction has not changed a whole lot. What has changed is the absolute terms. So what happens is you have around still 15 to 20% relative risk reduction and in mortality. But what happens in absolute terms, it means less because the absolute risk of event has decreased. Let's say the absolute mortality is around 30% in 1990. You have a 30% relative risk reduction. 30% of 30% absolute risk reduction would be around, bring it down to 10. So the absolute risk reduction, right, bring it down to 20, right, roughly around. So the absolute risk reduction is much larger for the same relative risk reduction, but the absolute risk reduction now and the number needed to treat is going to be much higher because absolute risk of event has decreased over time. So the relative risk reduction, the change has not been a whole lot, whereas the absolute risk reduction for the same treatment effects has decreased and the number needed to treat has increased, largely because of the declining event rates. So that is one. And so how do cultural differences play into both seeking hospitalization and what is the culture of doing procedures in various countries? Yeah, so that's a great question. So in Japan, so one thing what we noticed was this is despite adjusting, we did sensitivity analysis and adjusted. So how does cultural difference, the question is how do cultural differences alter treatment patterns? So whether the procedural utilization is because they have more sicker patients or whether it's due to cultural differences. That's a great question. So the thing is, so we actually performed, even despite adjustment, you're going to have residual confounding. And to the best of what we could do, what we observed with a multivariate adjustment and sensitivity analysis is these procedural utilization, there's a significant contribution to cultural differences and not just severity of disease. For example, as I mentioned, the coronary artery disease rates were lowest in Japan, but the stenting rates were highest in Japan. So that just tells us it's not just the disease severity, it's just a procedural practice patterns are quite different. And what is important is because these practice patterns are actually some of the endpoints which we use in trial. That is that heart failure, hospitalization, need for revascularizations are used in cardiology trials as endpoints. So as I pointed out, it could not necessarily mean treatment differences. It could mean just the practice pattern.
And also we have a few questions in the Q&A box as well.
The Q&A box, yeah. Do large EHR datasets provide data on readmission, prevention efforts such as home care, psychosocial support, and virtual follow-up visits? I think this depends on which electronic health records you use. Some of the records from Scandinavian countries and UK, you're able to capture quite a bit of, you don't have the reports, but you'll have reports of if there is a visit, home care visit, or some of the virtual follow-ups. And all the consistency is trial design is, or would you suggest trial design to be designed based on some of the differences you state in different countries? That's a great question from Janet. So what one way, in my opinion, could be is people have talked a lot about this of it's very difficult to have individual trial designs for individual countries. So because the overall trial design has to be same. But one thing, there could be many innovations in this. Some of the designs which have been thought about is cluster randomization. You randomize particular clusters to one treatment because there's less to figure out the differences in practice patterns. That's one design which has been thought about and has been attempted too. And then last question. I have a question regarding composite endpoints being used as primary major outcome. So there's a question on composite endpoints being used as primary major outcome, CV death and heart failure hospitalization, as heart failure hospitalization mostly drives. I think this is an issue now, largely because heart failure, when you have composite outcomes, you give equal weightage to both outcomes, but the predominant driver is just one outcome. But when you're reporting the study, you're actually reporting that it reduces both. But because it gives equal weightage. The problem comes is in diseases with higher mortality, we are forced to have composite outcome. Two reasons. One, because when you have high mortality, it acts as a competing risk to heart failure hospitalization. So if you're only going to check heart failure hospitalization, you can have false interpretations because the mortality could be a competing risk. That's so that is an issue in diseases with higher inherent risk of mortality in trials with where you're testing diseases with high mortality.
I think we are almost at time, so we won't take any more questions. Once again, Varun, many thanks for joining us this morning, and also thanks to all the audience for joining us today. If you'd like to register for our upcoming speaker series, both our grand rounds that happen on the first Tuesday of the month and the speaker series that happens on the first Tuesday of the month and the grand rounds on the third Tuesday of the month, you can find the list of the speakers and register through the link provided in the chat. Thanks again, everyone. Have a great day and see you in a month. Thank you.